Welcome to Grand Rounds, March 2025. Today we have Dr. Sean Stanislaw talking to us about axial spondyloarthropathies. Dr. Stanislaw graduated from Lebanon Valley College with a Doctor of Physical Therapy degree, completed his orthopedic residency training at the CPRS orthopedic residency in Lancaster, Pennsylvania. He is board certified in orthopedic physical therapy, and he is currently a fellow in the St. Luke's University Health Network Spine Fellowship. Dr. Stanislaw practices orthopedic physical therapy and is a facility director with physical therapy at St. Luke's in Spring Township. He believes in collaborating with his patients to develop a treatment plan that not only increases their function, but also gives them the tools to manage their symptoms in the future. He's been involved in the treatment of patients of all types, from patients trying to regain their functional independence to professional athletes. He has extensive experience treating operative, non-operative, and occupational and ergonomic conditions. So, as a reminder, make sure you scan the QR code or use the code on the left side of the screen to sign in. And at the end of the presentation, make sure
Yeah.
I don't know.
Okay. All right. Sorry about that. So we good?
Yeah.
All right. Um, so for everybody's sake, I'll be saying axial disease a lot instead of saying axial spondyloarthropathies, uh, dozens of times. All right. So going through really boils into two different classifications. So you have ankylosing spondylitis, also known as radiographic axial disease, and that's because it causes damage to the S joints and structural changes can be seen on the X-ray. And then a newer classification here is the non-radiographic axial spondyloarthropathies, which causes damage, but it's not visible on X-rays and it may show up on MRIs. All right. So why do we care? All right. Um, the reason we care here is because it has a high rate of disability and increased morbidity, mortality, uh, losses of work time, high lifetime health costs, and impacts to the individuals. All right. In France, they looked at the total healthcare costs being 3.6 times higher than the rest of the population. And the further the delay in diagnosis, the higher those costs go because further structural changes occur. And in some cases, they need different medication, which can be more expensive. All right. These Patients that are affected with this condition are also tending to be working age adults. So that has larger societal impact because these people, if they do go on disability, they're no longer contributing to the larger communities and have increased costs for the community. Um, on average, these people do have additional illness and comorbidities, and it results in more lost work time. There we go. Okay. So for these patients, they're typically 20 to 45 years old, and that's at time of onset, not necessarily diagnosis. A lot of times, diagnosis will occur in the person's 40s or 50s just due to the delay. Incidence rate is kind of all over the place, depending on what research you're looking at, but it's anywhere between roughly 0.13 and 1.4%. The study out of the UK puts it at 1 in 200, which is actually twice the prevalence of multiple sclerosis and Parkinson's disease. So it's not super rare. It's you will see these people coming through your clinic. All right. Ankylosing spondylitis is more common in men than women. However, now with different screening tools and the MRI and non-radiographic axial disease being identified, that the non-radiographic form is just as common in women as it is in men. So we just talked a little bit about delays, and that really does contribute to a lot of this disease. You can see there that the time to definitive diagnosis is approximately 10 years. Some current evidence is putting that anywhere between 6 and 10 years. Um, and any improvement that is noted is typically attributed to the improvements in MRI and more commonly available screening tools. All right. The one thing that I want to point out there at the top is just that people know something's wrong here. All right. 60% of them are going to some type of healthcare provider within the first year of having symptoms, but it's still taking that long to actually get them a definitive diagnosis. All right. So what could be causing this type of delay? Um, Now, some people also contributing to this, they don't feel listened to or believed about their symptoms, and that can cause them to withdraw from even seeking care, which would contribute to the diagnostic delay as well. Um, Another part of this is just that with the primary feature being back pain is just so common. 20% of the worldwide population in the age group that's affected here is going to be having chronic low back pain. All right, 80% of people are going to have low back pain at some point in their lifetime. And comparatively, the axial disease rate is significantly lower. Okay, so by all rights, healthcare providers are going to think horses, not zebras. So they're going to just assume that there's a not, well, a separate cause for their low back pain versus going to this right away. Um, and the suspicion might also be lower just due to poor awareness of the differences between mechanical low back pain and inflammatory low back pain as well. All right. So speaking with a lot of physical therapists here, we have more musculoskeletal training than your average healthcare provider. So we definitely identify these patients faster, right? Nope. Unfortunately, we don't. Actually, the average time is 6.4 years. So that's the average. And the other slide was 6 to 10 years. So we're really right in there. 44% of the people had at least 3 episodes of care with an average of 11 visits. So we're talking up to 30 visits of PT before this person was diagnosed. Okay, so that's not great. We still have work to do. All right. So it boils down to the question is, can we identify these people any earlier? All right, that's not a new question. All right, in 2016, in Great Britain. They did find that just basic education on symptomology and screening tools had a 40% improvement in recognition and referral. It's essentially what we're doing here today. All right. Physiotherapist awareness of the NICE guidelines was also linked to increased recognition and referral. All right, so barriers. This is from a patient's perspective. All right, so long wait times, insurance restrictions, either not enough uh, rheumatologists or too far to get to them, or just reluctance to get into more of this. Also, or excuse me, only 7.4% of people had no issues getting in for the referral to a rheumatologist. All right. So that definitely does create barriers and can delay getting a definitive diagnosis. So inflammatory back pain. All right. This may be a little more difficult to see on your screen. So I'm just going to read those 5 questions here quickly. All right. And this is out of the ASAS criteria as well. Okay. So does your back pain start did the back pain start when you were younger than 40? All right. Did your back pain develop gradually? Does your pain improve with movement? Do you find there is no improvement in your back pain when you rest? And do you suffer from back pain at night, which improves upon getting up? All right, so 5 yes/no questions. And the criteria shows that if a person answers yes to 4 or more of those, then their inflammatory back pain warrants further diagnostics or investigation. Okay. And there is also listed some additional criteria to consider as well. So the goal of the screening, as you're going through, and this screening can happen very quickly as you're going through, uh, you know, your subjective exam. If you start getting some of these flags or indications that might warrant asking a few further questions, that's when you're going to implement this stuff. It doesn't need to be big, cumbersome. Uh, that takes a lot of time with this. All right. But we're trying to identify patients prior to radiographic findings so that we can limit the structural disease progression, disease effects on other symptoms, secondary to the systemic inflammation, and trying to limit the long-term disability. Okay. So going with some of the symptomology, all right, they're going to have axial joint involvement, right? We all kind of assume that one. The inflammatory back pain is not mandatory for this, all right? It's not present in 20 to 30% of these cases. Enthesopathy, association with the HLA-B27, and some of the extra-articular manifestations, uh, which we're going to be talking about more at length here, and that's your uveitis, psoriasis, IBD, and some cardiopulmonary impacts as well. Enthesopathy, all right, 1/3 of the patients with axial disease present with clinical enthesitis. All right, it's overuse related pain at a site of insertion of tendon into the bone. And I do have tendon there, but it's really tendon and ligament attachments to the bone uh, for that. Um, Okay. So there is a higher prevalence of clinical enthesitis with the non-radiographic axial disease versus the AS. Inflammation and other functional enthesis, including those of the eye, lung, and aortic root, are also common in axial disease. This may explain some of the extra-articular disease manifestations, such as the uveitis, lung fibrosis, and aortic root disease that goes along with a lot of these patients as well. All right. So I thought this was actually a pretty interesting photo here because it has on uh, for the axial disease as well as peripheral disease for multiple sites and gives the incidence rate here. So some of the things that we would normally associate with more of an axial type location, looking at the PSIS, For the axial, the incidence rate is reported between 6.7 and 32%. And for peripheral spondyloarthropathies, the incidence is 31%. So it's almost the same. Um, so just seeing how that changes with peripheral versus axial findings, and even if we look at something that's more peripheral, like the Achilles tendon, all right, axial, that's up to 27% versus 28%, and that's repeated throughout. So I thought this was interesting. All right. So uveitis, there's a strong correlation with axial disease, and studies have shown 20 to 40% of patients with anterior uveitis meet the diagnostic criteria for axial disease. 1/3 of patients with active acute uveitis will have active radiologic findings. Okay. And that correlation is the highest in people that are over the age of 45 and have chronic back pain, which makes sense. For psoriasis, there's some photos, different kinds there. So psoriasis, 1/3 of spondyloarthropathy patients will have psoriasis with that. The axial disease in psoriatic arthritis study found approximately 24% of patients that had psoriatic arthritis also met the diagnostic criteria for ankylosing spondylitis. Um, Skin and nail psoriasis is seen with patients with the spondyloarthropathies, and it is not commonly found in patients who have rheumatoid arthritis. This can be helpful in differential diagnosis. Um, honestly wasn't super familiar with the nail psoriasis, but it's characterized by the pitting and damage to the nails there. That type of thing might be something that, as you're talking with a person, sitting, taking subjective, you might note, and it could be something that spurs some further questioning as you're going through your subjective. So going with the irritable bowel disease here, spondyloarthropathy can occur in 13% of people that have IBD. Right. Other skin manifestation, the hidradenitis suppurativa is a newer uh, extra-articular manifestation that's gaining some traction in some of the research. It's also a chronic inflammatory skin condition that causes scarring and everything. It's fairly common at 1 to 4% of the general population, and it has a high correlation with the HLA-B27 as well. 10% of patients with axial disease will develop HS. Um, and what you might find is that the HS actually precedes diagnosis of the arthropathy just due to how long it takes for patients to be identified. All right. So in the screening and axial spondyloarthritis in psoriasis, iritis, and colitis cohort, they recommended a three-stage evaluation approach: clinical evaluation, labs, and radiography. 47% of patients with psoriasis, anterior uveitis, and colitis were found 45 and over 45 years of age, 3 months of undiagnosed back pain, were diagnosed with axial disease. Of those patients, 2/3 of them were able to be diagnosed just after clinical evaluation alone. All right, and then it required further diagnostics. All right, so we'll talk about imaging here in labs. Talking about with the radiographs, looking at lumbar and SI joints. This was historically used, is less commonly so now because it is going to rely on there being structural changes that can be identified. There's a high inter and intra observer variability. Um, so it's not used commonly, or shouldn't be used, I should say, it shouldn't be used commonly in identifying and screening for these people. Um, So MRIs have largely taken over for the early diagnosis, and that's because it has allowed early detection for inflammatory foci um, and structural changes compared to the radiograph. Um, Using the MRI is what has allowed and facilitated the identification of those non-radiographic cases. Um, it also is looking for bone marrow edema and other causes of inflammation that can be identified with that can't be picked up well with radiographs. There still is debate on what would be considered a positive MRI, and there's inconsistent application on the part of radiologists on the recommended protocol for these patients. CT scans also gaining more traction as well, especially for monitoring patients that are already identified, because it is more accurate and sensitive for those spinal changes than what the MRI is. And part of that makes sense because CT is more sensitive with the bony structures. All right. So, radiographic disease progression is more evident in males. All right. Due to this and the previous reliance on the radiographs, uh, ankylosing spondylitis was mostly thought of as a male disease with 3 times higher diagnosis of male to female for AS. The lack of imaging findings in females can result in delayed diagnosis and underreporting of the disease incidence. So I mentioned earlier that the rate of non-radiographic disease is thought to be approximately equal in males and females. All right, for labs. All right, no definitive biomarker or immune phenotyping tools currently exist. Um, we are pretty much looking at the HLA-B27 and CRP. Those are the most commonly used. Less used would be things with the ESR, and some are going in with other autoimmune identifying markers as well. Um, the CRP utility might be lacking due to sensitivity and responsiveness. One study put the sensitivity at only approximately 50%, just due to fluctuation in inflammatory activity from person to person. And also, even within the same person, across time. Okay, so not all axial disease patients are HLA-B27 positive. There is a large variation based on ethnicity. So Caucasian and Northern European, the association is as high as 90% with the HLA marker, whereas African ethnicities is only approximately 50%. So this does potentially lead to delayed diagnosis in certain populations where the HLA negative trait would be more common. All right, talking about some of the classification tools, this is really important for what we're doing. It makes our job easier because we have some good information out there on what we should be looking at and then what to do with it as well. All right, so the ASAS criteria, um, it was initially in 2009 and then updated in 2015. We have the SPADE tool, and then the nice 2017 guidelines. So the ASAS guidelines, you're going to refer to a rheumatologist if a patient with over 3 month onset of chronic back pain before the age of 45, and they have at least one of the following there. All right. So that's the extra-articular manifestations, some family history. They really respond well to NSAIDs when it might not otherwise make sense. Um, your different laboratory markers, inflammatory back pain, all that stuff that is listed there as well. Okay. So the spade tool, all right. This was one that I wasn't previously very aware of. Um, it's super user friendly, I will say. I would suggest that you take a look at that, and I'll tell you the exact website. I know it's in my references, but um, it's very user friendly to use, and it's 12 questions that you just mark which findings are present for the patient. You mark it, you hit calculate score, and then it will give you the category based on the probability for that patient. So it will group them into either axial disease improbable, additional tests necessary, probable diagnosis, and definitive diagnosis. Okay. So it is very useful there. Okay. So you put that information here. You can see on the left of your screen, you'll see the criteria. So inflammatory back pain, heel pain, peripheral arthritis, dactylitis, iritis, or the uveitis, psoriasis, IBD, positive family history, good response to NSAIDs, raised acute the acute inflammatory markers, the HLA-B27 and sacroiliitis shown on MRI. Some of those you're not going to have access to right away, but you just put in what's there, what you do have access to, if you're one of the first people to be asking these questions. Um, and it will still give you good information here. The results page, for example, of the results are there on the right side of the screen, and it puts them there it lists the probable diagnosis at 80%, definitive diagnosis 90%, um, probability there. So gives you some information. All right. The 2017 NICE criteria. Um, you're going to refer patients with four or more of the criteria or three of the criteria with the HLA-B27 positivity. Again, one drawback in our setting necessarily is that they might not have that uh, the genetic testing already done. So if you're seeing a person, you're going to need to coordinate with their PCP um, or other providers to potentially get the uh, laboratory testing done. Um, I'm not going to read all of the criteria, but you can see that there on the left side of your screen. All right. So now what? All right. Positive screens should be referred to rheumatology for definitive diagnosis. All right. Sooner they receive definitive diagnosis, sooner they can start on pharmaceutical management, and that the management can begin. All right. That does make a difference because time to diagnosis and pharmacological management uh, can reduce the progression of the radiographic disease or damage. Early disease can be treated with NSAIDs um, and diagnosis within 4 years from the disease onset. Uh, Patients starting the anti-tumor necrosis factor therapy. Uh, all right. That can be effective there. The anti-tumor necrosis therapy gives a better response if the duration of symptoms is shorter than 10 years. This is one of those things that does contribute directly to the cost of the disease because one, the further along the disease progresses with the increased duration, they will have more structural disease, more systemic inflammation that's going to be occurring. So they're going to be incurring higher healthcare related costs, as well as the medication that they may require uh, could be more expensive as well. So, I mean, in some of the European studies, they're using things as uh, over the counter, like over the counter NSAIDs with ibuprofen and naproxen, all that stuff. Um, and people can progress on that before they require more significant pharmacotherapy. All right. So looking ahead, so we talked about the screening and all the background information. So what are we going to do with that? All right. The goal is to reduce the diagnostic delay that people are experiencing. All right. The sooner we can get them in, the sooner we can get them the definitive diagnosis and proper care, the better off they're going to be. All right. So we're doing what we're doing here today, right? We're trying to improve education and awareness amongst healthcare providers to help pick up on the cues that these people that they're experiencing, all right, and trying to facilitate their care. All right. So we got to dispel some of the common myths within the healthcare community. All right. So one of those being that it's more male versus female. All right. As we discussed earlier, that would be true for the radiographic type. The non-radiographic disease is just as common in male versus female. So we need to be aware of that. Just as that's out there, as well as even another myth would be that, all right, well, we got to get this person some radiographs, look to see if they have sacroiliitis, and identify it that way. So this is something that we have better tools available to us at this point with increased sensitivity that we're able to actually identify these findings prior to there being structural disease. All right. So wider use of the published guidelines and screening, and then once we do the screening, if appropriate, we refer them and get the additional diagnostic testing. Um, if you are within St. Luke's, at St. Luke's, as part of the comprehensive spine program and advanced spine providers, we might not need to make that additional referral. You can talk with the advanced spine care providers about potentially getting the imaging and decreasing that time to get the person the diagnostics that they need. If you are unaware of how to do that, talk with your facility director, and we'll get you pointed in the correct direction with that. All right, so improved interpretation of the MRI results. This isn't going to fall within our scope of practice as physical therapists, but it does have an impact. So there still is inconsistent application of the ideal MRI protocols. And that, like I said, is not necessarily within our practice, but talking with radiologists, and as we can develop this sort of thing, that increased awareness will hopefully spread. All right. Closer collaboration between rheumatology and the specialists that are going to see these patients. So we're talking dermatology, gastroenterology, um, ophthalmology, and then physical therapists as well, in addition to your PCPs. All right. And then more widespread use of the spade tool and other screening tools. All right. So ask the questions. All right. So I mentioned earlier, if you see things like, some of the psoriasis, or you're going through their medical history and you see, all right, well, they have, some type of irritable bowel disease or some of the other extra-articular manifestations that we've been talking about, and they're coming into you for back pain. Start putting the pieces together and be willing to ask those questions. All right. So you see some of the pitting on their nails. Hey, tell me about that. Like, do you have any other skin conditions, anything else? And then be willing to make that referral to other providers if necessary. All right. We at St. Luke's are able to and should be making those referrals to other departments, other specialists, to increase the collaboration. Because we can utilize that and help facilitate this patient getting what they need. All right, so PT is needed. All right, the ASAS recommendations out of 2022 found that PT to help patients maintain mobility and exercise is level 1 evidence. All right, so we finally got something. All right, we're doing good. All right, so we can help these people. All right. Main takeaways. All right. Patients with diagnosis of axial spondyloarthropathy have a high risk for disability and early mortality. Physical therapists have a crucial role in this process to help identify and refer these patients earlier in the disease progression. As we talked about earlier, unfortunately, a lot of these people are seeing physical therapists, and we're still not getting them to where they need to be in a timely manner. People having up to 3 episodes of care before being identified, having that definitive diagnosis. So being more aware of these inflammatory patterns, the extraarticular findings, all of these things, we need to do a better job of making these recognitions. All right, with proper screening and earlier initiation of those therapeutic protocols, it does decrease structural damage and improves the functional outcome for these people. All right, time does equal function. If we are able to identify them earlier, get them started on the proper medication, it will limit the systemic effects. They're able to stay moving longer, keep working longer, be more engaged within society and within their own lives. All right. So I have all the references here. All right. And then I would be happy to answer any questions that you guys have.
Feel free to unmute yourself and ask questions or type into the chat.
Will I be able to hear?
Well, I do have a question. You mentioned a couple times about sex differences for uh, axial spondyloarthropathy. That said, is traditional radiographic ankylosing spondylitis that is still male dominant?
So the research on that is yes, it is more common in males. The actual amount that it's more common varies from study to study, but a common number thrown out there is that it's 3 times as common in males versus females.
Okay.
But women still can have ankylosing spondylitis. So it's not like they can't. It shouldn't be disregarded out of hand, regardless.
You mentioned that it's relatively challenging to determine. Obviously, the average is 6 to 10 years to take somebody to be definitively diagnosed. Um, is there, if you had to summarize things that you listened to in your history from your experience and from your research, and specific things from your physical exam, what are the kind of in a nutshell screening tools you use besides the online one that you mentioned
Yep.
that stayed? What are the things that you specifically would recommend that we look at? And maybe we're already looking at, but to put together to make that referral quicker.
So most of it is actually going to come more from the subjective portion of the exam versus the physical exam. All right. So, you know, with us here at St. Luke's, especially if the person is within the network, we do have the advantage that we're able to see different laboratory results, previous notes, all that stuff. For the patient, we have easy access, so we can utilize our chart reviews. So in talking with them and utilizing the chart review, if we're picking up, hey, all right, this person has some of these extra-articular manifestations, that should be raising a flag for you. They have chronic low back pain at the age of under 45. And then especially if they have the uveitis, psoriasis, IBD would be giving you more indication. All right. Plus, we're talking the inflammatory back pain. And I know earlier when I was going through the presentation, That's still only 70 to 80%, but I mean that's still a significant portion. So it is the majority. So you're asking those inflammatory questions and trying to differentiate between the mechanical, which would obviously we're going to tease a lot of that out with our physical exam versus the inflammatory, which we can get a lot of that information just based on subjective with the 24-hour patterning of their symptoms, as well as some of the other findings.
Cool. This next one you may have answered, and I apologize if I missed it. In I always recall learning that people with AS have more of the pain in the second half of the night.
Yeah.
Did that play out in the research, or is that just a myth?
So I believe I don't have it in front of me, but it's in one of the guidelines. I think it's the NICE guidelines. Um, but so that is still the recommendation. In general, they just say nighttime pain. Some are more specific and they'll say second half versus just night pain. But having pain at night is still the common thread.
Other questions? When you have a patient with spondyloarthropathy and you're working with because you worked with a number of people trying to get back to work who are trying to make sure they stay working. Is there any general advice that you can give or that you recommend that we give to patients to keep them in the workforce more effectively, more efficiently, and not break themselves down or go to doing not much?
So the answer to that question would probably determine whether they have already been identified and they have a known disease versus hopefully they're early in the process and we're trying to help facilitate getting them that definitive diagnosis. So if a person's already has active disease, they know they have it, and we're seeing them and we're dealing with some of the downstream effects of that.
Mhm.
General exercise is very important, trying to maintain whatever mobility uh, um, we can do. Also having to be cognizant of that it is an inflammatory process. So we're not going to typically want to be as aggressive, with some of this because we don't want to increase inflammation. So talking about uh, work pacing, exercise pacing would be very important for these people. Um, Depending on what their job is, the further answer might vary a lot. I actually did have a patient with AS about 3, 4 months ago. He was a 32-year-old construction worker. He's going to have a hard go. So, and he already knew that he had it. That it was active disease. So we did have some of those discussions, and we're trying to plan out, how he could help work with some of this stuff. So he was personally trying to get additional certifications for construction related certifications that he would have to do things quite as physical. So I'll give him 100% credit. He was trying to be proactive with that. But that is essentially what you have to do.
Okay. And I like how you mentioned about radiographs because that generally for ordering anything bone related, that's the automatic go-to. Um, so am I correct that CT and MRI are more indicated as the initial radiograph or radiography study or imaging study for spondyloarthropathy?
Yeah. So the MRI is considered the preferred method because it is has it's capable of identifying some of the inflammatory markers, which can be identified before there's actually structural change. So for initial diagnosis, early diagnosis, the MRI is preferred. For more detailed assessment and ongoing monitoring, you would be looking more at the CT because of the increased sensitivity to the bone structures.
What other questions do you guys have? Hearing none, please feel free to reach out to Dr. Stanislaw if you have any further questions or if you have a question about anything spine related. And um, or you may contact me and I will gladly get in contact with Dr. Stanislaw. Thank you again for attending, and please make sure to complete the quiz and the course evaluation. And again, we very much appreciate your feedback and look to use it to improve the content and the types of courses so that we can provide you with what you need. Thank you very much.